Yeah, sounds good. All right, Eric, take it away.
Yeah. Well, good afternoon, everybody. My name is Eric Boyer. I'm the Senior Program Officer here at the Alaska Mental Health Trust Authority. And if you've been to some of our webinars in the crisis stabilization series, this one's on trauma-informed care. And we're partnering, with Agnew Beck and then RI International based out of Phoenix, who has been really a innovator and kind of the gold standard for operating a lot of these crisis services that and all of you are helping us stand up around the state. So it's a pleasure to have Amy Pugsley from RI and Kevin Huckshorn join us. I won't give a long, detailed intro, but just so you know, the two of them are both licensed practitioners. They've got a lot of years of experience working in inpatient settings, residential settings, around crisis services. And they've got, I think, a real global perspective from thinking about trauma-informed care from, kind of a national perspective, but also regional, statewide. They operate in a lot of different states. They both have done quite a bit of work up in Alaska. They're both very familiar with Alaska. Amy is actually down in Juneau helping out our partners right now this week with Bartlett Regional Hospital, who's looking to stand up some of the crisis stabilization services. So very exciting stuff. They both have a long background of working with peers right on up through kind of the integrated teams. So I think it's great to be able to have Amy and Kevin come today and share kind of what they see as vital components and aspects of trauma-informed care. And with this, I don't know if Amy, if you're next or Kevin's going to start us up.
Yeah. Thank you, Eric. I appreciate that. And I'm just going to do a real quick. I'm very excited about the webinar series that we've been doing, and those of you that have been attending, it's a different topic each month, but really tied to why these topics are so important with crisis services and being able to really implement the crisis continuum in the communities in a very high quality and efficient way, so that communities are really getting the services that they need, and people are getting the care they need at the time that they need it by compassionate people that need it. And so we're really excited that we had decided that the idea of trauma-informed care and what that really means in crisis services and all services, but in particular in crisis services, is so important. And I'm really excited that Kevin has joined our team, has been with RI for a couple of years now, and we've just learned so much from her and the wealth of knowledge and experience that she has, that I'm very happy that she's able to bring this all to you all, because she does this with us regularly and helps us and our teams really ensure that we're providing the highest level of care and really thinking through this trauma-informed lens. So with that, I'm going to turn it over to Kevin and we'll go from there. Kevin.
Thanks, Amy. Thanks, Eric. And good afternoon. I don't even know what time is it there. Morning?
It's noon.
Noon. Okay. Good afternoon to everyone. My name is Kevin Huckshorn, and I am in Chapel Hill, North Carolina. Last time I was in Alaska was basically the January before COVID hit. And then we all got grounded, or I did anyway. So it was, much to my dismay, I really enjoyed coming up to Alaska. It certainly is the final frontier in a lot of ways in this country. And, hats off to you guys for your resiliency and just your work in general. I've really rarely seen an entire community, a state, but it's almost like a community in terms of the mental health system that was really working so hard to move forward and be progressive in your state. So with that said, what I'm going to talk about for about the next hour and 15 minutes or so is trauma-informed care. And the reason I titled this Another Behavioral Health Buzzword or a Mandate to Drive Practice Change is that, as you all probably know, sometimes when these terms of use are used a lot, like recovery, like trauma-informed care, they kind of almost lose their meaning after a while. And I can't tell you the number of times I've gone into a hospital or a system or a community mental health system, and they've labeled a lot of their policies and procedures using the word recovery and trauma-informed care. But when you go below the surface, really practices did not change. And so language is important, and it's a very good first step to start to use the language. But the next step, which is equally important, is to reflect those concepts in what we do every day. And that means the most brand new staff member on the night shift has to understand the concepts of trauma-informed care and recovery. So what I'm going to talk about a little about today is both the biopsychosocial neurological effects of trauma, and also just kind of introduce you to some of the concepts as described and researched really by our federal partners at SAMHSA and the National Child Traumatic Stress Networks all through the country now. And so I'm going to just get started. So starting out with, what is trauma? You know, trauma is another word that we hear used a lot and with reference to a lot of different situations. So what we're talking about here is individual trauma. And this is trauma that results from an event, or more often a series of events. It's not usually a one-shot deal. And that is experienced by an individual human being as physically or emotionally harmful or life-threatening, and has lasting adverse effects. And when we talk about that, we're talking about mental, physical, social, emotional, and spiritual effects. Back in early 2000, basically 2001, I was in Washington, D.C. I was working at the National Association of State Mental Health Program Directors. And I was leading the National Technical Assistance Center for States and Territories. And we started to see literature come out on the experiences of trauma in people in the public that were getting services in the public sector, in the behavioral health public sector. And after the first couple articles, people were shocked. And primarily that was because before the 2000s, if you even thought about trauma, which you probably didn't if you were in behavioral health, it was because you were working either in a VA system where you were seeing veterans coming back from war, often with PTSD or complex trauma, or you were working in a rape crisis center or a domestic violence service system. Those three different service systems were well acquainted with trauma and have been for years. What we did not know was the incidence and prevalence of trauma for not only the general public in the United States, but also for the people coming into the public behavioral health system. We also started finding out more and more, and that it will come as no surprise, that obviously children in child welfare, corrections, children in schools, developmental disability services, and actually many of the perpetrators of these horrific shooting events were basically victims of trauma, some of them serious trauma. From the ACEs study, which I'm going to go over in a little bit, we also saw the connection between traumatic life experiences, often as children, and poor health outcomes, early death, if you will, which was also fairly shocking. And these concepts really kind of exploded in 2002, 2003, 2004, because that's when all the literature started to be published in our best known journals. And so NASHBID, being NASHBID and kind of leading with SAMHSA on best practices, immediately got involved in researching these issues and figuring out how we could help states understand trauma, but also what a trauma-informed system of care looked like. So what do we know about trauma at this point, 20 years later? Traumatic life experiences are widespread, they're debilitating, and they cost a lot of money. Trauma has no boundaries. Anyone can be traumatized. Trauma occurs as the result of violence, neglect, loss, war, disasters, and other types of emotionally harmful experiences. And just a note about loss and neglect. At the very beginning of the discussions about trauma back in 2000, 2001, we really weren't talking very much about neglect or those kind of loss of a caretaker, what we call latchkey kids and things like that. And it became very clear pretty soon that while neglect is a kind of a softer, more invisible type trauma, for one population, the kids in the foster care system, the loss of a parent, regardless whether they're an addict, have serious mental illness, are violent or not there, is tremendous. It's probably the biggest loss a human being will ever experience. And as a child, it makes that experience even more difficult to comprehend and manage. Trauma is an almost universal experience for people with mental health and substance use disorders. And as we've learned through the public health experts, the best way to approach trauma in our service delivery systems is in a universal precaution manner. And since we all just went through years of a pandemic, we all should be pretty much experts on universal precautions, right? So universal precautions are those things you do to avoid having something worse happen. In the medical field, what we're talking about, for instance, is COVID. What we learned about were masks, social distancing, washing our hands, vaccines, right? Vaccinations. In regard to trauma, since it is such a universal experience, and we know that many will never talk about it, it is best to approach everybody coming into care with a trauma-informed lens. Also, it's really important to note and not get defensive about, and I've been in the field for 42 years, so I've been around a really long time. And it's sometimes hard to say these things, but for many, the nature and delivery of behavioral health services themselves are traumatizing. Unaddressed trauma leads to poor outcomes, and incorporating trauma-informed approaches is extremely important and quite doable, but pretty much only when your organizational leadership is committed to this to happen. This is not, integrating a trauma-informed approach in an organization, in a facility, in a service, is not generally something done by direct care staff. It needs to be led by the leaders of that service organization, and needs to be approached as a culture change. And again, your regular nurse working evening shift is not going to be able to make that happen in their organization. It really does need to be taken on as a culture change project by leaders.
Kevin, sorry to interrupt. Did you mean to stay in the title slide for this?
No, I'm going on and on. Uh-oh. All right.
Thought you were just doing a really excellent intro.
Yeah, no. It says I'm sharing.
Yeah, the view you were seeing is how, like, if you were trying to edit your slides, we're not seeing the presentation mode.
All right, let me get out and do it again.
And just so everyone attending knows as well, we also generally will share a PDF of the PowerPoints as well. So no fear that we've missed anything.
Yeah, I just went through 4 slides. So let's see, share screen. Hold on a minute. Just okay here. Do you see that? Am I back?
No,
No, we were seeing your screen before. It just wasn't advancing the slides. It just was on the first one.
Megan, do you have the PowerPoint? Can you just roll it for her? No? Okay.
if she wants to, if you want to email it to me, I can try to do that for you. I don't.
I
have
will
a
do
copy.
that.
I can
That's so-
pull it up.
Okay.
I think I have it for you, Kevin.
You do. I sent it to you last
Yeah.
night.
And you're on slide 4. Yeah, so you keep going and I will share for us.
Perfect. And I'll just say next slide.
Thank you.
Yeah.
Thanks, Amy.
Mhm.
Okay, so what we're going to talk about now is the impact of trauma. And I'm sure all of you have heard about the ACE study, but I like to go over it again just because it was such a foundational piece of work. And I think it's important to be able to understand it enough so you can talk to your staff about it. It has been replicated a number of times in a number of states and countries, including Canada, the UK, Finland. The whole western part of the United States did their own because they wanted to look at rural health as it compared to trauma and traumatic life experiences. So all that information is pretty available on Google. So the average childhood events study came about because two doctors, Dr. Vince Felitti and Dr. Robert Anda, met at a conference. And they were both struggling with the care of individuals who had some things in common. Dr. Felitti was a vice president at Kaiser Permanente, which is, I'm sure you guys are familiar with Kaiser Permanente. It's kind of like Blue Cross Blue Shield or United Healthcare. It's an enormous insurance company that does a lot of work with members that have behavioral health issues, as well as just general health insurance for people that we all get. The interesting thing about Kaiser Permanente, which is something to remember, is that Kaiser Permanente is a very expensive healthcare insurance. So if you and I lost our job tomorrow and we had to go find health insurance, we probably wouldn't go to Kaiser Permanente because it'd be about $1,800 a month. People that have insurance from Kaiser Permanente are generally getting that through their employers. And so that means they're working. And that means they probably have a mortgage and they're paying taxes and they have kids and families. They're basically middle-class Americans, okay? And so Dr. Felitti was a vice president, but he also had a day job. And his day job was working with morbidly obese people, over 400 pounds, to help them try and turn that around because of the health impacts of that kind of weight and that eating disorder. And what he kept seeing over and over again in his practice was that someone would lose 150 pounds or a little more than that, and they disappear. They quit treatment, and he couldn't figure it out. Meanwhile, Dr. Robert Anda, he was working at the CDC, and he was trying to find the link between adults who had chosen very risky behaviors like smoking, eating disorders, self-harming behavior, substance abuse, promiscuity, and how those link to early death. And he was trying to figure out sexually transmitted diseases, HIV, Hep C. He was looking at people who were ending up with COPD, chronic obstructive pulmonary disease from smoking, a bunch of different cancers, and things like that. Early death because of an accidental suicide. And he was trying to figure out why with this particular group of people choosing these very risky behaviors, not particularly enjoying the behaviors, even people that are substance disordered, there comes a time in their disease where they are no longer feeling high. They just feel like crap and they have to use to feel normal. So they got together at a conference and they recognized somehow in their discussions that a core concept here seemed to be early traumatic childhood experiences. So they developed a survey tool based on 10 questions. And it was based on the survey tool was designed for the responder to basically identify any kind of personal abuse or dysfunctional household experiences that they had had when growing up. And this survey tool was designed not for a child, for an adult like you and I, an adult, most of them were in there between 40s and 60s. So some of the questions were things like, did you have a parent who was an addict or an alcoholic? Did you have a parent who had a serious mental illness and was ever institutionalized? Did you ever see your parents hurt each other physically? Did anybody ever fondle, grope, or sexually penetrate you in any way when you were a child? Did anybody ever hit, kick, slap, or push you? Were you repeatedly made to feel bad about yourself? Did you ever see anybody get killed? So it was things like that. And so they sent out this survey tool to 18,000 Kaiser Permanente employed insured adults. And they got back roughly half of that 17,000 surveys, which is, for those of you who do research, is a phenomenal response rate. Usually for us that do survey research, sometimes we're lucky if we get 15%. We're like really happy about that. They got like 49% back. And what they found was that the experiences of childhood trauma was way more common than had ever been known before. And that what happened with mostly white, insured, middle-class Americans. So we're not talking about people that were homeless, where you expect someone to have experienced significant trauma. We're not talking about kids in the foster care system necessarily. We're not talking people that live in really horrible poverty or in very dangerous neighborhoods. We're talking about you and me. They also found that adverse childhood experiences did not occur in a vacuum. If one happened, more happened. So it was, it was cumulative. And in the scoring tool, you could have a score of 0, or you could have a score of 10 if you answered yes to every one of those questions. And last, most of the individuals that were surveyed and responded reported never or almost never talking about these issues, given the powerful social and role taboos about discussing these things. And that was higher in men than women, as you could probably guess. Next slide. So the findings from the ACE study, again, 17,000 participants were surveyed, roughly 8,000 sent back their survey tools filled out. And what was seen was female participants, 13% emotional abuse, 27% physical abuse, almost 25% sexual abuse, male, almost 8% emotional abuse, almost 30% physical abuse, 16% sexual abuse. And if you look at the kind of like pyramid, what we're looking at is on the bottom, once a person has experienced an adverse childhood experience, especially if it's repeated or patterned, the next thing that happens is that their brain develops differently from everybody else's. And they end up with what's called disruptive neurological development. And I'll talk about that in a minute. The next thing that happens is because of the disruptive neurological development, social, emotional, and cognitive impairments happen. And those happen on a big range. Some people barely have any, some people have a lot. From the discomfort that comes from experiencing social, emotional, and cognitive impairment and dysregulated neurological syndromes, you see the adoption of health risk behaviors. And, these are one of these places where I always say, when human beings don't feel well, their first goal is to feel better. We all have this, right? Most people are not okay with just feeling bad. So another thing that happens as a human being, depending where you live and your family, anywhere between the ages of 11, 12, up through maybe college, you get exposed to a number of risk factors. And those are things like smoking, using alcohol and other drugs, especially marijuana now that it's legal in a lot of places. You also basically end up learning how to, if you want to eat more food than your parents want you to, you figure out a way to get that to happen. And it's very individual. Some people they hated smoking, but alcohol was great and made them feel better. Some people smoking made them feel better. You hear most smokers say, if I don't smoke, I'm going to get really anxious. Food comfort, eating for comfort, another very common practice. So that's where someone walks through the door. And this is a little complicated because not everybody who experiences alcohol or tobacco or marijuana or food ends up with a problem. One of the things none of us know, because there's no marker that we know about yet, although we're learning more and more about this, is that we all have genetic risk factors to become get a disease like alcoholism or tobacco addiction or a food disorder. We all have those genetic markers, but we don't know we have them. So every time we experiment as a human being with any of those pieces, we stand the chance of activating that addiction. And you can talk to kids till you're blue in the face, and you can tell them, we've got addiction in our family. Your grandfather had an alcoholism problem, but most kids are going to completely ignore that, and they're still going to test. So that's where the danger point comes. But that's how you get the adoption of health risk behaviors. And in some cases, it's kind of hard to walk back. And then after that, you start seeing disease, disabilities, and social issues, and then early death. Next slide. So again, just another pictorial of the impact of early childhood adverse experiences. The blue is if you have one ACE score, so you only answered one affirmative to that survey tool. 4 is 4 or more. And as you can see, for all those illnesses and diseases listed on the bottom, heart attack, angina, asthma, cancer, COPD, arthritis, diabetes, and depression, you can obviously see the strong graded relationship between ACE scores and those adult diseases that will lead to early death in many cases. Next slide. So prevalence of trauma. Some of the foundational research pointed out that, for instance, in adults, life trauma experiences in the US were about 51% for women, 61% for men in the general population. Up to 98% of clients in the public mental health system had been exposed to severe trauma. Back in the early 2000s, the Commissioner of South Carolina, the Commissioner of Mental Health in South Carolina, decided to do basically a survey of every single client in the South Carolina behavioral health system, whether they were in hospital, in outpatient, or somewhere in between. And they did that, I believe it was in 2005, and they found 91% of clients in South Carolina had experienced one or more significant trauma events in childhood. We also identified up to 2/3 of men and women in substance use treatment reported childhood abuse and neglect, and that being abused or neglected as a child increased the likelihood of juvenile arrest by almost 60%. Next slide. So now we're going to move to the learning about the neurobiopsychological effects of trauma. These slides were taken with permission from the evidence-based best practice known as the 6 core strategies to prevent conflict, trauma, and violence in inpatient and residential settings. Dr. Glenn Sachs, who was at Harvard at that point, but is now in Cambridge, was the original author, although we have updated those slides to some degree. Next slide. Okay. So children develop along pathways cleared by the adults and caretakers in their lives. There's no more important role for an adult or child for an adult other than to be a child caretaker. Next slide. So some of you have probably seen this before. This is work done by Dr. DeBalis back in 1999. It was one of the first studies that showed that we could see trauma we could observe it physically. Up until then, also trauma had been considered kind of an emotional disease. You know, what is it? Well, you can't see it, so how do you measure it? Well, these are two children, two 11-year-old males. One of them was severely maltreated and has chronic PTSD, which is extremely high threshold to get to at 11 years old. And the other child is a healthy, non-maltreated, non-traumatized child, which is how they do a matched control. So they were similar in every way except for their experience of trauma. So the one, and so I'm going to point out to you the brain on the right. This is looking at from the back to the back of these two kids' brains, back the very back of it. You'll see that broad white band right over the brain. That broad white band right under the skull. Yes. Okay, so that is the brain of the traumatized kid. And what that white line shows, see how much bigger it is than the one on the kid on the left, the healthy kid, is that that brain has basically atrophied. It has shrunk away from the skull. You'll also notice some funny changes in the middle. Those little funny like triangles are called ventricles. And they're what bathes the brain in cortical spinal fluid. And so you'll see the difference between the healthy child and the traumatized child by the fact that those ventricles look much bigger in the traumatized child. And again, it's not that the ventricles are bigger, it's that the gray matter has pulled away and so has therefore enlarged the ventricles. Next slide. So effective behavioral health services, given what we now know about trauma, and especially in crisis services, must account for people coming in the door with a dysregulated nervous system and a social environment that cannot contain this dysregulation, which is why people get, in some parts of the country, pink slipped, in some parts of the country, involuntarily committed, Baker acted. Every state has its own term of use, but this is what happens when somebody is acting in a manner that the community, the social community, can't manage or contain or tolerate. So they come into care. Next slide. So I'm going to go through 4 concepts of development. The first is the growth of self-regulation. Emotional self-regulation is a cornerstone of early development that cuts across all behavioral domains. Next slide. So I'm going to give you 2 examples. This is Robert. This is Robert. He's a 22-year-old young man. He had a long history of childhood physical abuse from his stepfather. His stepfather had a substance use disorder problem and used to come home after work drunk and get violent. So Robert, being the identified patient, as often happens in families like this, who's now a pretty angry kid, he was sitting on a psychiatric unit, minding his own business and having a calm, continuous, and engaged day. He was fine. He was doing exactly what we want people to do when they're inpatient. Have a calm, continuous, engaged day. He looked up at some point from his table where he was sitting, and he saw 2 staff members standing along the wall pretty close to him, talking to each other. And one of them looked at him, and he immediately had a flashback to his father coming home, standing at the kitchen door, starting to make fun of him under his breath. And he immediately got aggressive. He jumped up, he tackled one of the staff members. And what happens in a psychiatric unit if you do that? Well, somebody takes you down. And that's what happened. He then later, in kind of meticulous debriefing, related that he got really angry, then he got very afraid, and then he disassociated. Okay, next slide. Okay, so this is Talia. She's a 12-year-old female. She had a history of being sexually abused by a parental friend, and she'd gotten treatment. She had a therapist, and she was back in school. So here she is today, sitting at school with her friends, talking to her friends. She's in a calm, continuous, engaged state. She's fine. She's listening to the teacher. and everything's fine. Until a boy leans over from his desk and says something demeaning to her about her breasts. She immediately becomes overwhelmed with shame. And in this particular situation, she got up, walked out of class, walked 2 blocks home, walked straight up the stairs to a medicine cabinet where she had hidden a razor. Her mother was home, ran up the stairs, grabbed her and took her to a therapist. Upon Dr. Sax's debriefing with her, analysis of this event, she explained that when the boy said that to her, she was completely overwhelmed. She no longer almost knew where she was. She got very afraid. And then she started to disassociate and went home. And all she could think of was to self-harm, to cut herself, because that was the only thing she knew from her experience would help her ground. Next slide. So when a child has been traumatized, or even an adult, but it's more severe in a child, and their brain does not develop the same as people who were not traumatized, things happen. And one of the things that happens is that when someone goes into an emotional state other than calm and continuous, their affect changes, their thoughts change, their behavior changes, their sense of self changes, and their consciousness changes. And if you look at that little square in the middle, if you can read it, what you'll see, every single symptom, if you will, on that little red slide also mimics basically every disease in the DSM-5, which is why sometimes it is so hard to diagnose trauma. Most people, especially up until maybe 10 years ago, most people with significant trauma were often diagnosed with different types of personality disorders, or sometimes even schizophrenia, a lot bipolar and depression. So they didn't even get the right treatment because we didn't get to the right diagnosis. Next slide. So emotional states in child development. This is an important concept too. Just even little babies have very discrete, i.e. different behavioral states. And that's how they start to learn to grow up and how they start to learn to manage their emotions. Infants' experiential world, because they don't have language yet, is divided into separate and definable emotional and behavioral states. Dr. Wolf studies babies, and he would go into people's homes that obviously agreed to this, and he would basically study infants and their experiences with their parents. A critical task of early childhood development is to build smooth transitions and bridges between states. So let me ask you something. How many of you folks have kids? You can just raise your hand. I can see most of you. Okay. So do you remember when you went home when you took your first baby home and you went into the house and you were probably exhausted and it was probably a day after you gave birth, and you basically went home? I'm going to move my screen a little and I'm going to have my little teddy bear here. Here's teddy bear. And I've got my baby. And so I get home, I'm exhausted. I go to put the baby down in the crib and the baby starts screaming. So what do you do then, folks? Did you just stare at the baby? Did you say, oh, forget the baby, I'm going to go out and do something else? Probably not. What you probably did was you picked back up the baby, and then what did you do? Did you just stare at it? No. You probably patted it, right? And you rocked it, and you rocked it, and you patted it, and you tried to see if it was wet or what it needed. Try and figure out, because babies usually scream if they're wet, if they're tired, or if they're hungry. How many times did you do that? Twice? 10 times? 100 times? How about thousands of times? And in doing that, you became your child's social partner, because in those activities over and over and over again, you taught your child that when they were upset, they were not going to die, and that you would help them calm down. And you did it over and over and over. And that helped them build neural pathways that were strong in understanding that they weren't going to die and they didn't have to panic and they didn't disassociate and all those kinds of things. So the regulation of emotion for a baby into an adult is initially contingent on caregivers facilitating those transitions. That's a super important concept. Next slide. So the goal of treatment, again, is to maintain calm, continuous, engaged states, prevent discontinuous states. And I'm sorry I'm using this language because it's the research language, and I always feel better if I'm sticking to the research language, but it's erratic emotional situations, escalated states, and that we start to help people practice building cognitive structures or rebuilding them because they may have never built them in the first place. If you're a child who grew up with a mom, a single parent family, where the parent was working 3 jobs and the older kids taking care of you when they remembered to, because they're trying to do their homework, you didn't have that consistent parenting, that consistent encouragement, that consistent practice in managing your emotions. If you grew up in a family where you were taken away from your parents at an early age and put in a foster care home, you also didn't get it, especially if you were in 6 foster care homes in the next 4 years. You didn't get any of this stuff. If you were brought up by a parent who had an addiction or had a serious mental illness, who are just incapable of being able to provide that kind of consistency in caretaking, same thing happened. So just think for a minute of all the kids in residential services in our country and how many millions of these kids, whether they're there or they're at home, have had very poor neurological development for all kinds of reasons, and how that brings them to us now. Next slide. So real quickly, this is human stress theory, Hans Seeley. It also has to do with our human smoke alarm, which is our amygdala. And whenever you hear me say amygdala, I want you to think fight, flight, or freeze. Fight, flight, or freeze. Our amygdala is 300 million years old. It was created to keep us safe from like saber-toothed tigers. It basically is very primitive part of our brain. It's always working, and it constantly scans our environment for danger. It is constantly scanning. Now, for most of us, we don't get triggered very often. Maybe you were almost in a car accident 2 months ago or something like that, and you had a brief amygdala response. But most of us don't go through our lives constantly triggering our amygdala. So what generally happens is a stimulus will happen and your amygdala will respond by basically telling your body to release a whole bunch of hormones. And those hormones are called catecholamines. And those are things like norepinephrine, epinephrine, dopamine, serotonin, cortisol, all kinds of stuff. And those hormones are what, when you're almost in a car accident and you weren't, but you almost were. And afterward, for those of you who've ever had that experience, you shake for like 5 to 10 minutes in your car, because that was your amygdala flooding your body, getting you ready to fight, flight, or freeze. So next slide. So that's the normal human response. Human development is shaped by a dynamic and continuous interplay between biology and experience. Again, going back to that, whether you're a person whose amygdala gets triggered a lot or not. Next slide. So I'm going to give you a picture. This is Eric's brain, and he was kind enough to send me a picture of it. It's a very nice brain. And I want to just point out 3 different areas that are important to understand with regard to the amygdala and with regard to trauma responses. So the first, if you see the amygdala, it's the very lowest one. And it's this little P-shaped thing. There's actually, it's actually, as you can see, very low down in the brain. It's a primitive part of the brain, and it just sits there. And then right next to it, and again, remember, amygdala is fight, flight, or freeze. If you go up one, now we're talking to the hippocampus. Now, for those of you, if you were there, if I was there with you, I'd say, who knows what the hippocampus does, but I'm not. So the hippocampus is responsible for memory and context. Okay, memory and context. And then the third part of the brain I want you to think about is the prefrontal region. That's the CEO of the brain. That's where decisions get made, thoughts get mediated, responses get determined. It kind of is the air traffic controller of our brain. It's a very important part. Okay, next slide. So in a normal stimulus and response, you've got the stimulus, you almost run into a truck. That response in milliseconds passes through the sensory thalamus and straight to the amygdala, which starts firing immediately. But for most of us, again, who have a normal amygdala pathway, just a few milliseconds later, that same response hits the hippocampus, which says, okay, I almost was in an accident, but I wasn't. I'm okay, they're okay. And even though we're sitting there shaking because of the adrenaline that just got pumped into us, we're already starting to calm ourselves down. And then the cortex, a couple milliseconds later, says, okay, everybody, everything's good. You're going to be okay. Kevin, you're still shaking, so you should probably sit here for a little bit so you can drive safely. And so just sit here, maybe turn on music, maybe call somebody. You're going to be okay. That is the normal human response to when your amygdala gets triggered. Next slide. Okay. So now what we're talking about are people who've been traumatized repetitively as at a young age. What happened to them is every time that stimulus occurred, it did the same thing, went to the sensory thalamus and it went straight over to the amygdala, okay? And it did that over and over and over, and it got faster and faster and faster. And I know you've all heard the term your brain, we've now learned that the brain is a muscle. We can exercise it, we can learn new things. People learn to dance at the age of 88. We now know the brain isn't just like us sitting there doing nothing. We all know that the brain, we tell older people in terms of warding off dementia to play Sudoku, to play crossword puzzles, to do anything to keep their brains active. Well, this all has, that concept is important here. So in this child, that amygdala pathway from stimulus to response becomes extremely strong and extremely fast. And because of that, the first thing to go is that the cortex, the pathway to the cortex gets extremely much slower and much weaker. Next slide. So now our CEO is kind of checked out. The next thing that happens is our hippocampus does the same thing. So now our memory and context checks out. It just kind of leaves the picture. And now all you've got is a raw, unmediated panic response. And that response is generally fight, flight, or freeze for these young people and people that grew up in these environments. Next slide. So treatment for these kinds of disorders, these trauma-affected neurological issues, are social environmental interventions and neuroregulatory interventions. And those are really big words that are really a little bit more simple. So let me tell you what those mean. Social environmental interventions, I mean, I don't want to be too simple about it, but it's basically great customer service. It is basically when someone walks in your door, you want them to feel incredibly welcomed, very safe, like no one's making fun of them, like they're an equal person. And you also want to have an environment that is calm, that is warm, that is non-institutional, that basically has art on the walls, not a bunch of posters saying the rules of the unit and what you can't do, because that's not particularly welcoming. I mean, how many of you guys have welcoming signs where your clients walk in? Are they in different languages? Are the staff trained to immediately go to the door and say, Amy, come in. Oh my gosh, I haven't seen you in a couple of weeks. What happened? You know, please, can I get you a shower? Can I get you some clean clothes? Can I get you something to eat? As opposed to, oh my gosh, guys, here comes Amy. She's back here for the 4th time in 2 weeks. Real different. And clients pick up on that stuff. So when we talk about social environmental interventions, we're talking about modeling great customer service, a la Disney World, a la Marriott hotels, just to be kind of simple about it. It also means using things like sensory modulation, colors, scents. You know, we have all these skills as humans because we've grown up this far. And I don't know about you, but the last time I sold my house, my realtor said, we're going to have an open house and a whole bunch of people are going to come. And I said, okay. I said, well, I'll put some cookies out. She said, no. She said, I want you to make popcorn. I want you to make popcorn in a microwave, and I want you to keep making popcorn, because for 99.9% of human beings, popcorn smells really good. It brings you back to really fun times when you're a kid, going to the movies, blah, blah, blah. She said, and it's just a really helpful response for an open house. Now, I don't know if that had anything to do with it, but I sold my house in one day. It probably was more than that. But so that's the kind of thing, thinking about these kinds of things that would make you feel better. Neuroregulatory interventions are also really interesting. Now, this is where we start talking about psychiatric drugs, especially the antidepressants, which seem to have an effect on mediating this fast amygdala response. I am not a psychiatrist or a physician. This is what the research tells us, and that's what many of the doctors that I practice with understand and use. Another is gross motor exercise, because we now know that you can build new brain neural pathways through basically flooding your brain with oxygen. It's called volume oxygen, and the only way you can get your volume oxygen up is by aerobic exercise. So we're talking playing basketball, running around in a field, playing volleyball. And, you know, obviously some of us have very limited ability to give that opportunity to our guests, but sometimes we do have that ability, especially in outpatient services, even just to get them on an exercise routine. That can be very helpful. Next slide. Okay, so next slide. Also, it's other stuff in there, biofeedback, social resilience learning, Lori Leach's work. There's an awful lot of other like evidence-based practices that are very helpful in helping people relearn their responses. Okay, sorry, next slide. Okay, so this is like probably my favorite study of all. This is Jacques Panksepp. Jacques Panksepp studied rats, laboratory rats. So these are rats that just lived in a laboratory. And first thing he noted about rats, especially babies, is that they played all day. And rats play in two ways. One of them are called dorsal contacts, and one of them are called pins. Next slide. So Dr. Panksepp did this brilliant study, really brilliant study. So he's studying rats, and he basically looked at their play solicitations, which means one rat would go to the other, like puppies do and kittens do. One rat goes to the other rat and kind of indicates they want to play, and then the rats start playing. And he also looked at play solicitations and also pinning and tumbling. And so he got a baseline for that. And that's that black mark on the top. That's the baseline for rats playing. He then one day walked in to the laboratory, and he took a pair of tweezers and he inserted a single cat hair into the cage of these rats, a single cat hair. And guess what happened? For 24 hours, all play stopped. Now, this was fascinating because these are lab rats. They don't know what a cat is. The parents don't know what a cat is, and the grandparents don't know what a cat is. But because they've got that primitive 300 million year old amygdala, it knew something was really dangerous there. And they responded to that. 24 hours afterward, he took the cat hair out of the cage, and guess what happened? Play never resumed back to baseline for the rest of those rats' lives. So this study just kind of shows how a traumatic event can have kind of effects that we would never imagine them to have. Next slide. So how to understand trauma and traumatic reactions, which, you know, we all call escalated behavior, violent behavior, aggressive behavior, scary behavior. So what we've learned as we've moved forward down this path from 2000s is the response to traumatic stress is often a learned behavior. Think about Talia going in and trying to decide to cut herself, to ground herself because she knew she was disassociating. That's learned behavior. May look very aberrant to us because it's not pro-social. You can't just be out in public and take out a razor and start cutting on your arm. People are going to respond to that and not in a good way. But for her, it was learned behavior because it had worked before. Same thing for someone who, even someone who's newly in recovery for substance abuse, doing okay, comes home, wife says, I'm divorcing you. 9 out of 10 times, that person is either going to call their sponsor or they're going to go out and drink and they're going to relapse. So response to traumatic stress is a learned behavior or a habit and needs to be unlearned and replaced with something more pro-social. For any of you guys that have ever tried to quit smoking, go on a diet, think about how hard that was. That's what we're asking our clients to do, to relearn these immediate, not pro-social responses, emotional responses that often get them in trouble and hurt people, and to relearn those. And to do that, they have to be in a safe place where they trust us. The survival response impacts the mind, body, behavior, and speech. And in these kinds of times, for these people that have untreated trauma, the amygdala basically takes over. In some ways, once that happens, the person really doesn't even have control anymore. So to change the response, we need to create new learning and skills. And we do that by getting to know the person, because if we don't know them, they're not going to particularly participate in treatment or listen to us. So we want to figure out what their main triggers are. We do this through safety planning. We give them a list and we try and sit down in a quiet place and we go through what makes you feel bad. Loud noises, being treated unfairly, people that look like they're in police uniforms, being told no, things like that. And we find out what that, people touching you, all those, everybody has different triggers. We all do. So we try and go through with that person and analyze what their trigger responses are. Then we want to do the second part of a safety plan is we want to say, what makes you feel really good? What do you do when you start feeling stressed that makes you feel good, that doesn't include smoking, drugs, alcohol, or food? So it might be things like taking a shower, going for a walk, calling a friend. And speaking about calling a friend, what's the first thing we do when we put people in involuntary settings? We take away their phones and their computers, which is their often lifeline nowadays to their friends and their support systems. The state of Massachusetts has basically moved forward to allow cell phones in all of their institutions. And that's a conversation for another day, but there's a really good reason for that. Most of us could not even imagine being without our phones for a day, let alone for a couple of weeks. So that's just something to think about. But anyway, so we want to look and see and identify with that person. What do you think would make you feel bad if you feel good if you started to feel bad? How can I redirect you and get you into a safer place? And then after we've done that, then we practice it. And sometimes it doesn't work. Sometimes the person just said, oh, I think taking a shower will help me. And they escalate. You go, Kevin, come take a shower. You said that might help you calm down. And I basically say, F you, that's not going to help me calm down. So then we're going to go back afterward and say, well, that didn't work. So let's think of something else that might work in that period of time. What else might work? And so this is slow going, but it has to be done for people that have these traumatic life experiences and these neural changes that can't be fixed in any other way. Next slide. Third core concept is human relationships, and the effect of relationships on relationships are the building blocks of healthy development. I'm just going to bring out this one piece with regard to Crisis Now services. What we have found at RI, and the reason after I knew RI back in 2010, when I actually had the luck to know about them and to bring them into Delaware, because we had a significant problem with people in crisis sitting in our emergency rooms or being taken directly to prison. And it was horrible. And we just didn't have any other services. It was a big gap. And they came in, and within a year and a half, we're diverting 97% of the people that normally would have gone to prison or into an emergency room back to the community almost immediately. So What I noted then, and I still note now, is that the addition of the peer support workforce in the behavioral health system of care is probably the most important thing that's happened in over 50 years. They are innately ready to do this work, and they do it beautifully. Yeah, they need to be certified. Yes, they need some training. Yes, they need some training on boundaries, because that's not stuff we get born with. But they're basically, and I don't like to generalize, but I can tell you 9 out of 10 of the peer support specialists I've worked with over the years, they are compassionate empaths. And that's what you want on your units. These are people that are, they ooze empathy, and they are extremely helpful with clients who have had very bad experiences in other settings, because peers can decontaminate those earlier experiences, because people don't forget how they were treated in the last hospital they were in. And sometimes that was well. I'm not trying to say all hospitals are terrible, they're not. But all I need is one bad experience, one brand new staff member, one poor decision made in the moment. At RI, we call this peer-powered engagement, but we also expect that empathetic engagement is a mandatory competency for all behavioral health staff, and it's on us during our hiring process to really focus on that and to figure out behavioral health interviewing questions that can lead us to some understanding if that person has that kind of empathetic engagement skill. Next slide. So the course of development can be altered by effective interventions that we know about, that can change the balance between risk and protection, and then shift the odds toward that person having an effective recovery, hopefully into the community, because people don't recover in institutions. Next slide. So again, recovery, this is just a little slide on what I was talking about a little bit before, promoting neurogenesis, new brain neural pathways. This is also called lifestyle medicine. A lot of peers follow this course in their RAP plans. So we're talking about exercise. We're talking about use of antidepressant medications in some situations, cognitive stimulation, and kindness always. When clients come into our care in an involuntary setting, they are disproportionately dependent on staff to meet their needs. We've just taken away their ability to meet their basic needs. And staff, often we have not trained them to understand that not only is that a super important role for staff to play, it can't be whenever they want to do it. It has to be immediate, because that's when people get really unhappy. Next slide. So the implementation of trauma-informed care approaches differs from trauma treatment. Trauma treatment is for people who have been diagnosed with PTSD and things like flashbacks, acute suicidal behavior. That's not what we're talking about here. We're talking about a universal approach in creating our environments of care and training our staff. Trauma-informed care principles incorporate relational elements. Again, customer service that provides a sense of safety, empowerment, trust, and respect. It's not a structured program, it's an approach. It's a culture change. It happens in our milieus. In behavioral health, unlike many other businesses, if you will, most of us, I never had a customer service class, and I've been in school for like a million years on and off. No one ever gave me a customer service class. And especially in the public sector, we've never had to worry about customer service because we had too many clients in the first place. We're not out there banging the doors for clients. Usually we've got way too many. So nobody ever told us about customer service. However, if you look at other fields, engineering, marketing, computers, IT, all the manufacturing businesses, they are like all super well educated in customer service, because they know if they don't have customers, they go out of business. So we have to actually go back and repair that. And we have to teach our staff the importance of customer service, and you want people to want to come back to you when they need to come back. That is a critical component and a very important outcome to have. Because if not, then we're just kind of repeating this, the poor outcomes that we get. Next slide. Another piece to think about in terms of trauma-informed care, especially in locked behavioral settings, is the power imbalance. Individuals coming into care lose a lot of rights. The minute the police pick them up, they lose rights. The rights that most of us take completely for granted living in America, we wouldn't even, I mean, if for any of us, if someone came, like if a cop came right now downstairs and knocked on the door and said, I'm taking you to the hospital involuntarily because one of your neighbors complained, I would be really unhappy and really scared and mad and all those kinds of things. And they take my phone, I won't be able to call anybody. I mean, just think about that experience. It's traumatic all by itself. So they lose their rights. And these are, a lot of the times, these are folks who are adults, and they get in, and again, that unnatural dependency I was talking about. And so staff need to be very sensitive and to minimize that power differential in all kinds of ways. I have been in innumerable inpatient settings where staff walk around with big banging janitorial key rings. Why? What is the message there? I got the keys and you don't. There's no reason to do that. That's the subtle stuff that we have to start to think about. Also, a lot of places I've gone, the first thing you see when you walk in is a list of rules of all the things you can't do. Nope, can't do this, 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 can't do this. Instead of those rules, put up what you can do. We hope you're going to be comfortable here. Please come and talk to the staff if you need anything. Let us know if your room is too hot or too cold. Peer support specialist, blah, 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 is assigned to you for the next 2 days, and you call them or talk to them anytime you want. Or these two, this one on days and this one on nights, and do something like that so that people, because can you imagine being admitted not only to the scary place or a place you've heard about to be scary, but then you're put in a room with some stranger that you don't even know? How many of you guys would even have a roommate at this time of your lives, that like just an old roommate? I mean, there's just certain things that we are expecting our clients to do that are incredibly uncomfortable and that are so normal to us because of our work settings, we don't even think about it anymore. Next slide. Okay, so now we're down to the last part of the training. So what I want to talk to you a little bit about is implementing a culture of trauma-informed care. And these couple slides are based on just a phenomenal amount of work that SAMHSA has done, and with our federal partner, our behavioral health federal partner, has done all across the United States, funding research, funding traumatic stress centers, and supporting publications. And so you can find this on there. They have a toolkit on trauma-informed care also. I think it's maybe only 4 or 5 years old, so it's pretty current. So this is how you go about doing it. The first thing you do is you basically introduce your workforce to the prevalence and impact of trauma, like you just heard today. They can take it or leave it, right? But what you want to do is your part is to make sure that they get this information. So you want to train staff on the trauma basics, be careful who you hire. Most anybody can keep it together for an hour interview. So it's critically important that we ask behavioral questions that make someone think. There's no right or wrong answer here. Behavioral health questions are questions like, okay, Amy, so I'm just going to give you a scenario. You're sitting behind the desk, you're waiting for an admission to come in. The peer brings the person into the big room with their little bag of clothes, and the person all of a sudden drops the clothes on the floor, says, I don't want to be here, runs back to the door and starts pounding on the door. What are you going to do? What would your first thought be, Amy? And so Amy, as the applicant, is going to be able to give me kind of her first thoughts of what she would do based on her experiences. There's a lot of answers there. One of them isn't call a code. Okay, that would not be a good answer because we don't even know what's happening yet and nobody's in danger. But that's what I'm talking about. Those kind of behavioral interviewing questions are really important when we hire staff because we can't make them take psychiatric tests, right? And then also take care of your staff. Just like we take care of our guests, you've got to take care of your staff, and the staff will know it. If all you're telling them is take care of the guests, but I don't care that you had to work 4 days straight, and you didn't get any time off and we had to call you in midnights because somebody called out, that's what they're going to remember about how you're treating them. So take care of your staff. Next is train all staff that they are mandatory reporters for abuse and neglect, and make sure that you clearly describe what abuse and neglect is, because even if something bad happens on the midnight shift or on the afternoon shift, usually that doesn't happen in a super private area. Someone else sees it happen, and we need to know about it. And people need to understand they're not, we've all grown up with, you know, you're a tattletale, you're a, you know, what do you call it? Whatever that word is with an S. But we really have to explain to staff how this is part of quality improvement and performance improvement, and that we all have to adhere to these really important tenets. The second is recognize the signs and symptoms of trauma. We do that generally by doing a fairly simple assessment of trauma symptoms on admission. And then we also watch for signs. And that would be things like isolative behavior, poor eye contact, insomnia, anxiety, being afraid, like if you're afraid of women or you're afraid of men, and really trying to engage that person on admission, whether it's outpatient or inpatient, engage them as quickly as you can so you can ask them some of these really difficult questions. Did anybody ever hurt you in your life? And again, some people will never tell you, but most will. Violence is often due to a lack of emotional self-regulation, especially in the face of shame or humiliation. Martin Luther King has this great quote: violence is the language of the unheard. And I think that says a lot about that whole issue. Next slide. Third is integrate knowledge about trauma into policies, procedures, and practices. So this is a fairly big one. And we actually have some resource documents that go into this even more. But in general, what we're talking about here is if you can have all the knowledge about trauma and what it does to people in your head, but if you don't concretize that information into policies, procedures, and practices, it doesn't really have an effect. So things like changing our thinking on violent behavior from what is wrong with you, the client, to what happened to you as a person. Oftentimes, people's responses in crisis are survival responses. They don't work very well many times, but they worked sometime in the past, and so they're hung on to. We also need to make sure that staff understand the situational model of violence. If you go into literature, which we did when we were developing the 6 core strategies for preventing conflict and violence, 99% of the research that had been done on violence in inpatient setting blamed the patient. Okay. And the studies were all about going in and doing studies and medical record reviews to identify the violent client. And I'm talking billions probably of dollars and decades were spent trying to identify the violent client. And of course, there is no one type of violent client because violence is much more complex than that. Violence also has to do with the environment and the other people in the environment. So it's a 3-legged stool: staff, environment, and client. So the situational model of violence basically says that any one of those pieces could be the trigger, and that we can't just blame the patient for getting violent. We have to really understand what happened, like a story. We need to be able to tell the story of what happened and include the perspective of the guest. Another piece of this is that staff should seek to help people bond and attach, not only with staff, but even in the milieu, playing games, listening to music, watching TV, doing groups. The groups don't have to be, super boring. Don't have to, and every group doesn't have to be anger management. It can be all kinds. There's all kinds of groups we can do nowadays. Learning how to do a RAP plan, learning how to establish controls, learning how your body feels when you start to get upset. That's different for everybody too. Some people's teeth clench. Some people start like moving their hands. Some people start getting restless and walking up and down. Some people immediately retire to their bedroom and close the door. So it's helping people start to get really in touch with their body, because if they know they're starting to get upset, that can trigger their use of their safety plan. Next slide. Actively avoid re-traumatization in the service setting. Critically important, cornerstone of trauma-informed care. Do everything you possibly can to do not be confrontational, do not use limit setting, do not use points and level systems with consequences, and try not to ever use seclusion and restraint if you possibly can do that. Sometimes we have to, we miss the boat, we miss the cues, and we have to keep everybody safe, but then go around and try and decontaminate what just happened. So avoid practices that use consequences, because we are not parents and we are not the police and we are not judges. And so what we do should be very engagement and relational, not you're bad and this is what you did that was bad and this is what's going to happen because you did it. That's the problem with points and level systems. Avoid paternalistic approaches, which I've seen less and less over the years. When I started working in Florida in like 1982, I guess it was, there was a lot of the staff know better than everybody else, and you're supposed to listen to us. And what do you mean you don't like your medication and it gives you too many side effects and you're not going to take it? Well, I'm not changing your medication because that's the best medication for you, and so you just need to take it. Well, how short-sighted is that? My doctor gives me a medication that makes me gain 50 pounds, makes me slur my words, makes me be really super stiff, can't go out in the sun because I get acne. You think I'm going to take that medication? No way, no way, no way, no way. And then I come back in and it's like, Kevin's non-compliant. Guys, hello. So watch your language. Gosh, I talk about this. This is my soapbox, so I'll try and control it. We can't talk about people as diagnoses. We should never call someone a schizophrenic or a borderline or antisocial or crazy or needy or manipulative. It's not only disrespectful, and it's a defense mechanism on our part because it helps us push them away as the other. It says, you're different than me, you're the other. I'm going to call you something that's not really human. But it's also, they hear us talk about them, and that does not build engagement or respect or trust, because people know what we're saying. And I'm not saying anybody on this call does this, but I'm sure somewhere in your lifetime, you have heard someone do it. I hear it on NPR sometimes. I cringe, and I always want to like call them up and say, what are you doing? But anyway, so language. There's if you just look up recovery-oriented language, there's so much out there now on how to avoid this kind of psychobabble. And then need to create environments where help seeking is seen as a positive skill and rewarded by attention and help. And again, peer staff are invaluable here. Next slide. Actively avoid, again, this is just a continued practice de-escalation skills with staff. I know everybody has their own training program. I am just going to put in a plug because neither RI nor me have any conflicts of interest here, but there's a new training that just got put out that is called Yukuru, and it is one of the best trainings I've ever seen in my entire career. It also incorporates the 6 core strategies, which is in the public domain, and anybody can have it for free, as the only evidence-based practice on how to basically teach these skills to staff, because these are skills that we are not born with, guys. Or maybe if you were born in a family with 10 older brothers, maybe you learned de-escalation there, but in most cases, we didn't learn this as kids. Understand that people who are behind locked doors are dependent, and that we need to meet their needs, and we need to meet them quickly. Stay in the milieu and observe constantly. No more sitting behind the nursing station and all the plexiglass. That's one of the things I really liked about RI when I joined, was that we routinely take out all the plexiglass. And help staff to understand the basics of customer services. It's often just ignoring someone's needs that gets them to start to escalate. It's just as simple as that. Next slide. I think I'm almost done. Oh, implement sensory modulations. Yes. If you've got an OT in your area who has been trained in behavioral health, at least get them on as a consultant. Sensory modulation equipment and practices are incredibly powerful and effective. So we do a sensory assessment, which all of us, most of us either sensory seek. Those are the risk takers, the adrenaline seekers, or we sensory avoid. And sometimes we're both, we're pieces of both. You can like red hot fireballs and classical music. So it depends on where you're at that day, that minute, what you might like. But but you want to find out, because then you can use the modular sensory modulation equipment like weighted blankets. These are vests that are very tight and feel like a hug. We identified those as useful for dogs that get panicked by lightning, those thunder coats. It works the same for some people. Weighted stuffed animals, music, warmth, warming up a blanket in the microwave, sensory rooms, smells to help with grounding, frozen oranges, sour candies, fireballs. For people that cut, we often, for people that, cut, not lethal cut, but cut to ground themselves. Often what works is either rubber bands, or they can get they're called brushes, like brush your hair, but they're little brushes. And they can just brush their skin, and it gives them almost the same sensation as cutting, but it helps transfer that cutting habit into a brushing habit. And then you can slowly start to phase that out. Next slide. And then personal wellness plans for staff. I won't go through this because we're almost out of time, but just to let you know, not just do our clients benefit from a wellness plan, but staff can too. And in some agencies where I've worked, both the client or the patient has their wellness plan and the staff have their wellness plan. And they sometimes talk about it in between each other because we're all humans and we're all stressed by life, especially the last 3 years. So there's nothing that's like really good stuff to do because you're modeling this really good behavior. And again, the social reliance resilience model, social resilience model by Lori Leach is really interesting, and it doesn't cost a lot of money, and it's really very helpful. I was trained in that a couple of years ago, and I still use it. Next slide. Okay, now I'm done. So I'm sorry I went over like 8 minutes farther than I wanted to. Is there any questions? And also just to let you know beforehand is, if anybody doesn't want to have a question here in front of everybody and you just want to write me, feel free. Questions, comments, thoughts?
Hey, Kevin, I had one question. This is Eric. In Massachusetts, have they had enough time to evaluate the effectiveness of bringing in, allowing them to use media, phones? Yeah.
Yeah, I think they have. Let me make a note. I'll get
that'd be great.
The assistant commissioner. I'll call her tonight and ask her if they've done any studies, or even if she has a gut reaction. I know what they did was they did it with child, adolescent, and adults. And you had to be competent, which most everybody was. And they had to agree. They just signed an agreement that if they put a red sticker over the camera lens, like one of those heavy duty red stickers. And if they could, they disable the video. Most phones, you can't do that anymore. They were told, if you misuse this phone in a way that could harm anyone else, you will lose the phone for the rest of your stay. No discussion. And when I was there, they'd done this for about 6 months when I was there, and they had like 3 people lose their phones in that whole system. So, but I'll find out.
Yeah, thanks. I appreciate it. That's amazing. I mean, that puts a statement on, trying not to re-traumatize people in this day and age. So.
Right. Especially in this day and age where the first thing you do is pick up a phone to call a friend if something bad happens, especially if you don't have a family member to call, or the family member is the one you're calling about.
Yeah, I just wanted to say I really appreciated your presentation, Kevin. I think as I was just thinking about, oh, this is coming up tomorrow, I think in my head it's like, oh, I know RI is going to do a great job talking about how it's more than just a buzzword, but that your title was really like exactly what I had in my head, is like, how do you take this from something that everybody is familiar with, oh yeah, we're trauma informed, to like, no, like this is what it really means to live this on a daily basis in a facility. And so I really appreciate it. I had to miss a little bit of the end, but kind of some of those really concrete tips that you gave at the end about how to do that. So thank you.
You're welcome.
Yeah, and I would just add, one of the things that I think, and Kevin's done an amazing job here at RI over the last several years of working with us on this, is really just understanding that you don't know where anybody has been. We make a lot of assumptions when someone's coming in crisis or an emergency room or that type of thing. And being able to just remind ourselves, like, we shouldn't make assumptions. We don't know what that other person is going through, because they don't know what we're going through either. And we have to kind of check both sides of that in order to be truly trauma informed, and know what not only our own situations have been, and be more aware, self-aware of those things so that we can interact the best, but then also really making it so that those environments that it is about caring for another human. And sometimes we need to let go of some of those other barriers. And I think that's, one of the things that I take away every time I hear Kevin talking, is that all of these different scenarios could happen to any one of us, and have happened to many of us. And so understanding that, the ACEs, if you ever looked it up, if you haven't, you should. That survey, most of us who think that we're pretty well normal functioning, we'd score on that survey, right? Because it's about the different kinds of things that can happen to anybody. And I think that's eye-opening to how we then in turn treat individuals that are in a crisis situation, and why I think we really focus on the crisis now model of, we're not defining what someone's crisis is for them. It's not about what we think a crisis is. It's what is that crisis to them, and how do they see that crisis impacting their lives, and then how can we help them through that, not deciding what to do for them. So thank you, Kevin, for a great presentation.
Well, thanks, everybody. Stay warm.
Thanks.
Don't let
Thank
the
you.
news get you.
Thank you.
Thanks everyone for joining.
Thank
Yeah.
you.